bulk of your exam will be on internal medicine. As part of internal medicine, the cardiovascular system is very high yield. And as you can see here, we have almost 9 different topics to go through, and these topics will have their own subsections. I will try my best to make it easy to take the basic understanding of the cardiovascular system, connecting it with its clinical application so that you can get to the point, know what you need to know, and do what you need to do. Again, let me repeat our goals for the course. We have 3 goals. The first goal is to be able to take the basic science knowledge and combine it with the clinical understanding so that you can be able to make the connection. The second goal is to be able to gather enough information to pass the exam. The third goal is to be able to get the scores that you need, that you want. It will depend on your effort, the amount of questions you do, the amount of resources you turn to, the amount of times you watch the videos, and the depth and the level of understanding that you have with each one of these topics. With that understanding, let's go over the topics for cardiovascular system. In the cardiovascular system, unlike most courses, we are going to talk about the clinical presentation, rate and rhythm diseases, heart failure, cardiomyopathy, valvular heart disease, vascular disease, infections, pericardial diseases, and wrap this up with congenital heart diseases. In that regard, then, let's talk about clinical presentation. In clinical presentation, essentially, you need to understand why is the person coming to the hospital? What is their signs and symptoms that lead you to believe that this might be a cardiovascular complaint? This is in the clinical setting. On your clinical vignette, you should have the same train of thought. What will make you think this is a cardiovascular question? Clinical presentation, you will take a history and a physical, and you will do some testing. In general, the history and physical in most cardiovascular cases can give you more information in this pathology. Let's talk about the history first. In taking the history, you want to get a complete description of what's going on. Does the person have chest pain? Is the pain described as pressure? Is it heavy? Is it localized? Is there an onset time dependent? Is there a specific duration? How long does it last? More than 30 minutes, less than 30 minutes? All of that can give you a clue into the specific type of cardiovascular disease. Precipitated factors are very important. Is it precipitated by exercise? Does it happen at rest? As you can see, my train of thought, this gives you a clue on how to really tackle cardiovascular questions. This is the same way you're going to tackle it on clinical knowledge as well as clinical skills. Let's continue. For the physical, it's very important when you walk into the room. As a clinician, the first thing every clinician does is to do what is called the general inspection. By knocking onto the door and walking in, you generally look at your patient and see their state of being. Are they restless? Are they sweating? Is there tachycardia? If they're on a monitor, is their heart rate, is it elevated? Is it low? What is their blood pressure saying? Are they hemodynamically stable? So these are the things that you watch out for. If you look at their physical appearance, are they profusely sweating? Do they seem uncomfortable? That's what you will look at in terms of the general. Then as for the vitals, what is the blood pressure? Are they hypotensive or hypertensive? Do they have a fever? Maybe the fever was recorded by the nurse. Maybe it's on the monitor. Whatever the case may be, do you think they have a fever? Sounds. If you do your physical examination and you listen, are there new heart sounds that was not there before? If this was a established patient, do you hear any sounds in the lungs? Does it sound like crackles or rails? You ask these questions, and it takes you a split second. Once you master this, it takes you a split second to be able to answer these questions in your head as you do your physical examination. Causes. This is where the bulk of your questions will come from when it pertains specifically to the clinical application of the cardiovascular system. The vascular cause is the most important one here because vascular, cardiovascular, because it's specific to the system. In this case here, when we say vascular causes, we say things like acute coronary syndrome, stable versus variant angina, aortic dissection. Let's talk about acute coronary syndrome. Acute coronary syndrome is a subset of pathology that's specific to the coronary vessels of the heart, hence the name acute coronary syndrome. The etiology for acute coronary syndrome will be unstable angina, end-stemming, and stemming. All right, unstable angina can usually comes from pathology such as a person with an unstable plaque in their coronary vessels, which may rupture and leads to an abrupt occlusion of that vessel, and that leads to chest pain, which is angina. Non-stemming on the other hand is non-ST elevation myocardial infarction. In non-stemming, the only difference between non-stemming and stemming is that non-stemming does not show any ST elevation on the EKG, but it is still a heart attack. Stemming, on the other hand, is ST elevation EKG. This is your classic MI, or classic myocardial infarction. Then you continue and say, well, in terms of the vascular causes, variant versus stable angina can cause that as well. Variant angina, another name is Prince-Metal angina, which is form of a spasm, coronary vessel spasm that led to angina. You have stable angina, which again is chest pain, but this is happening secondary to a stable plaque within the coronary vessels that led to hypoperfusion of the heart, leading to chest pain. Then another vascular cause that's very high yield, and we should give this a star, is aortic dissection. Again, remember, here we're just talking about clinical presentation of chest pain. We're not going into detail of the specific pathology. But let's talk about aortic dissection. The most common etiology of aortic dissection is hypertension. Recall that you can see aortic dissection in collagen vascular disease. You can also see that in syphilis. If you want to get more detail, you can refer to the pathology videos as we talked about syphilis and its connection with aortic dissection. Clinical presentation, person may be hypotensive, they may have a new onset murmur, and they may have a pericardial tamponade, signs and symptoms of pericardial tamponade. Again, when we get to the aortic dissection, we will talk about that in more details there. But the key thing to get is that the person has a dissected aorta and there's regurgitation or backflow of blood to the heart. That's going to lead to hypotension. And because that regurgitation is going back into the left ventricles, which eventually goes to the left atrium and goes back to the lungs. That whole process, you can hear a sound, a murmur, because of the regurgitation flow. And in some cases where it doesn't go back into the heart and it gets into the pericardial sac, the person will present with signs and symptoms of tamponade. Diagnosis, you have an X-ray, an MRA, you have CT, A, and a TEE. The TEE is tracheoesophageal esophagram, which is the most sensitive, most accurate way to diagnose aortic dissection. But these diagnostic methods from X-ray to MRA to CTA are solely dependent on the person's hemodynamic stability. The more hemodynamic stable a person is, the least invasive and least expensive method you will use to see if they have aortic dissection. The more hemodynamically unstable they are, the faster method you need to use so that you can do something about it. Because it is said that people with aortic dissection have a mortality rate of something on the order of 2% per hour. So that's very, very, very important. Now, as we continue, we know that vascular is important because it relates directly to the cardiovascular system. We have the two serene sound here to tell you that these two pathology are gold mine. In pulmonary causes, because we know that the pulmonary system is within the thorax and you can experience chest pain in there, we still got to be cautious to be able to rule out myocardial infarction. Chest pain, there are two main reasons why a person may have pulmonary chest pain. One is pulmonary embolism, the second is pneumothorax. In pulmonary embolism, there's always classic presentations. Pleuritic chest pain is important. When a person takes a deep breath in, they experience chest pain. That's usually should clue you into pulmonary causes, especially pulmonary embolism. Hemoptysis is also classic there. There is different criteria and things to go through. We will do that in a specific video. As we move on, we say the patient may have dyspnea, tachycardia, non-specific changes on the EKG as well. On history and physical, you may find that the person may have history of DVT. They may have risk factors of that. They may also have a previous diagnosis of DVT. All of that will give you a clue that this person's chest pain is likely pulmonary cause. The second one is pneumothorax. These individuals have a sudden onset of chest pain. So watch out for a person who's probably tall or has a history of COPD or has had a trauma, a car accident or something that led to the pneumothorax that presents with this chest pain. We move on then to infectious causes of chest pain. Again, remember, our goal here is simple. Our goal is to rule out the most acute causes of chest pain or the most fatal causes of chest pain and then go down the list. So infectious causes, we say pericarditis, myocarditis, and pleuritic chest pain. In pericarditis, we are talking about an infection around the heart within the pericardial sac. That's important. Myocarditis presents with chest pain, which is the most vaguest clinical vignette you're going to experience. That's exactly how the person presents, and that's how the clinical vignette will present. Vague chest pain, they may have a history of viral infection, they may be very young, and on X-ray, you may see an enlarged heart, or at least an enlarged cardiac silhouette. Pleuritic chest pain, on the other hand, we say is chest pain which is associated with friction rub and is associated with the person breathing. Then you move on to GI causes. Of course, with all of these, GI causes seems to be the most common of the reasons why a person may have chest pain. And one of the reasons why is because of GERD. GERD is one of the most common reasons why a person may present with signs and symptoms of chest pain. But let's talk about peptic ulcer disease, and then we talk about GERD, and then we talk about GI butts type chest pain. Peptic ulcer disease, again, person may have an epigastric type chest pain. It's associated with eating. We know this has to do with ulcers in the stomach, and just read your clinical vignette to know that this is away from cardiovascular and this is towards GI. GERD is the most common reason why a person may have signs and symptoms of chest pain. These individuals are usually have chest pain that can be released with antacid. It can be associated with food intake. GI buds induce chest pain, the most common of which we talk about is either the gallbladder or the pancreas. These are the two buds of the GI system that most frequently will present with chest pain that mimics or similar to heart attack type chest pain. In these individuals, for the pancreatic chest pain, they may have chest pain that's radiating down towards the back. It's like this penetrating type chest pain going towards the back, whereas in the right upper quadrant chest pain that may radiate to the shoulders, you're dealing with the gallbladder. Next is chest pain due to the esophagitis. There are about 2 or 3 main reasons why a person may have esophagitis or chest pain induced by the esophagus. One is that individual who has HIV, individual who may have HIV infection that can lead to candidiasis, cytomegalovirus, or an individual who takes in a lot of pills and it leads to pill-induced esophagitis. Let's talk about those with the HIV who may get candidiasis or cytomegalovirus. In these individuals, when they have candidiasis or cytomegalovirus, it may lead to organophagia, which is pain on swallowing. They may have plaques in their mouth. The plaque is important to distinguish the CMV from the candida. They may have ulcers. The ulcer is also important. If you have a circumferential ulcer, you're talking about CMV, so C for C. If you have a longitudinal ulcer, you're thinking about candidiasis. So circumferential ulcer, CMV. When you're thinking longitudinal, candida. And another way to distinguish the two is the CD4 count. People with HIV who has a higher CD4 count, maybe 300, maybe 400 in that, or even 500 in that vicinity, may be more prone to getting candidiasis and candida-induced ulcer. When it comes to CMV, the CD4 count is less than 100. That's a way to distinguish the two. They may also have dysphagia. As we continue, pill-induced esophagitis can also appear in individuals with HIV, or it can appear in any other population of people who takes in a lot of pills. The reason why I say HIV individual is because they take a lot of pills. It's musculoskeletal disorder. In these individuals, the best way to diagnose it is to look for a chest pain that can be palpated. Patient may tell you, I have a chest pain, blah, blah, blah. If you push on this, chest pain. If you push on this, chest pain. They can localize the chest pain. That gives you a clue that this is a musculoskeletal induced chest pain. But just understand that there's a strong clinical context behind getting the question right in the cardiovascular system. I made this the first video because if you can understand how to piece out the information, that's exactly how you're going to read your clinical vignette so that you can arrive at the right conclusion when they ask you what is the next best step or what do you think this is, or blah, blah, blah.